My name is Brian Wood, Medical Director for the Mountain West AETC ECHO. Welcome to this week's session, and I will turn it over to today's speaker.
Thanks, Trisha. Thanks, everyone, for giving me the opportunity to talk about these findings. I'll be talking about increasing methamphetamine use among non-MSM who inject drugs here in King County. And first, I want to acknowledge my co-authors and collaborators who represent folks both at our public health department in Seattle and King County, and then here at the University of Washington, and of course the CDC for funding part of our data collection. I think of all the audiences I've presented to, this one probably knows better than most that at least here in King County and other urban areas, that HIV risk appears to be highest among men who have sex with men who also use methamphetamine. These are some data that we've collected here in King County to show the prevalence of HIV infection among some of the key at-risk populations. And these data are from a CDC-funded surveillance study that I'll be talking about more in depth later, called the National HIV Behavioral Surveillance. In King County, we estimate that the HIV prevalence among MSM who use meth is probably somewhere between 35 and 45%, as compared to the prevalence among all MSM, which here in King County is about 17%. This is in contrast to the prevalence among people who inject drugs, and when we exclude MSM, we see a fairly low prevalence of around 3% locally, and then among the surveys we've conducted among heterosexuals at higher risk for infection, we see a very low prevalence of less than 1%. Recently, some of our colleagues here in Seattle, some of our substance use colleagues, have identified indicators locally of increased methamphetamine use, or at least signals of increased methamphetamine use. And there has been a recently published paper from Denver by one of my colleagues on the National HIV Behavioral Surveillance System demonstrating similar trends there, and I definitely recommend looking at this paper. I think it's probably going to be a fairly seminal one, also showing increased meth use there. However, the reports that we have locally, as well as the Denver paper, do not show if the increase in meth use is among MSM, where use has historically been concentrated, at least here, or among non-MSM, both men and women. And it's also not known if these networks, these MSM and non-MSM networks, are connected through injection equipment sharing practices. So the objectives of this analysis were to try to answer those questions. First, we described the temporal trends in meth use among people who inject drugs in King County, and we stratify that between MSM and non-MSM. And the non-MSM that we looked at were men who have sex only with women, or MSW, and then sexually active women. The second aim was to estimate the frequency and characteristics of equipment sharing among people who inject meth. To do that, we used data from two serial cross-sectional surveys of people who inject drugs here in King County. The first is the surveillance system that I mentioned previously, or NHBS, which is a CDC-funded surveillance system that we've conducted locally for 12 years. And every third year, we focus on people who inject drugs, and this is known as the IDU cycle. This has been conducted between 2005 and our last cycle was in 2015. To be eligible, people need to report injecting any drug in the past year and also show some physical evidence of injection or provide enough detail to convince the interviewer that they are indeed a drug injector. To recruit, we use something called respondent-driven sampling, or RDS, which is a form of incentivized peer referral. So folks who are enrolled and complete the survey are then given coupons to give to their acquaintances, who then can be recruited into the survey, and the index patient is then given a small incentive for recruiting people into the survey. Participants complete a quite lengthy behavioral survey. It takes about an hour to complete, and in that survey they answer questions about a variety of things, and for this analysis we're focusing on the data they provide about their methamphetamine use, their equipment sharing, and characteristics of their most recent sharing partners. In NHBS, we also conduct screening for HIV and hepatitis C. Our second survey comes from program evaluation conducted here in our health department at our syringe exchange program, or SEP. This has been going on for about 15 years or so, and for this analysis I'll be focusing on our four most recent surveys, which are conducted every other year. In fact, we're conducting one right now. To be eligible, people basically need to walk into the door of one of our syringe exchange programs. There are no other eligibility criteria. It's conducted using a convenience sample over a 2-week period, so quite different recruitment strategies as compared to NHBS. And those clients are given a short survey. It takes about 5 or 10 minutes to complete. And questions for this analysis that we looked at include methamphetamine use, both alone or in combination with heroin. And you'll see this becomes a very important finding. We had a very insightful syringe exchange program staff years ago include a question about using meth in combination with heroin. And so we're able to get some pretty novel data from those questions, which we're not able to get from NHBS. And those surveys also include questions about equipment sharing as well. The analysis I'll be presenting is fairly descriptive. We restricted this analysis to people who inject drugs who also reported any sex in the past year to try to reduce any sorts of confounding bisexual behavior. And as I mentioned, we stratified our findings by MSM, men who have sex only with women, and sexually active women. The statistical methods I'm using, you'll see just frequencies, although to do a comparison of people who inject meth and heroin together to those who only inject meth, we used a form of regression analysis, which is described here. So let me give you a snapshot of people in both of these surveys. In the middle column, you see people who were enrolled in NHBS, and then on the right-hand column, people in the syringe exchange program. The average age is about 40 across the two surveys, with slightly older folks in the NHBS survey. About 2/3 of people in both of these surveys are men, and looking across that whole sample, about 10% are MSM, about 40% or so are men who have sex only with women, about 25 to 30 are sexually active women, and consistently between 15 to 20% of people who inject drugs report no sex at all in the past year. Our syringe exchange program recruits a slightly higher proportion of white clients, a slightly lower proportion of folks who are unstably housed. About 70% of people in both surveys report injecting daily, and between 15 to 20% of people self-reported overdosing in the past year. Because this is an infectious disease group, I'd be remiss to not mention these, although they don't really play into the rest of the analysis. About 7% of our IDU participants screen positive for HIV, and that includes both MSM and non-MSM, so that's why that estimate's a little bit higher than that first slide I showed you. And a whopping 71% of our IDU participants were positive for hepatitis C antibodies. So let's dig into the results. Well, the first key result was given away by the title. We have been seeing a dramatic increase in methamphetamine injection among people who inject drugs here in King County. This first slide comes from data from the NHBS survey, and the question asked about methamphetamine injection in the past year. You can see that use has always been consistently high among MSM, but the increases are most telling among men who have sex with women as well as sexually active women. In fact, in the 2015 survey, 2/3 of non-MSM reported injecting any meth in the past year. This slide looks very similar. In fact, sometimes I forget which slide I'm on, but these data come from the syringe exchange program. The only difference here is that people reported methamphetamine injection in the past 3 months as opposed to the past year. And you can see that the time frame is slightly different. It's a little bit later. But the trends are more or less the same, in fact, with a little less noise. The MSM rates are high, but you see this very clear linear increase among men who have sex with women as well as women. So the second key result is that we identified that most of the increase in meth injection, at least among non-MSM, appears to be attributable to people injecting meth and heroin together. And this is known locally as injecting goofballs. And so these data come just from our syringe exchange program. As I mentioned, that was the survey that included a question about goofballs. And this chart mirrors the previous chart I just showed. It's just that it's broken down by whether or not people injected meth alone or no goofballs in light purple, or they reported injecting goofballs, which is in dark purple. You can see there was a slight increase in goofball use among MSM, but that primary increase you can see was among men who have sex with women and women. There's a consistent 5 to 15% who report only injecting meth alone, so that's in the light purple. But that linear increase is almost entirely attributable to people injecting goofballs in dark purple. So I was curious about who these goofball injectors are. And so in this analysis, what we did is we compared people who reported injecting goofballs in the past 3 months to those reporting injecting only methamphetamine alone. And we restricted this to just non-MSM men and women. What you can see is that the goofball injectors tend to be slightly younger. There was no statistical difference in sex or race, but the goofball injectors do appear to be more likely to be unstably housed, more likely to inject daily, and more likely to report overdosing in the past year. And those were all statistically significant findings in univariate analysis. We did do a multivariate analysis. Our sample size gets a little squirrely here, but the overdose outcome remained significant in the adjusted model too. So now I want to move on to the second key aim of this analysis, which was looking at injection equipment sharing practices between MSM and non-MSM. So first of all, I want to talk about just sharing injection equipment in general, and I'll focus on 3 key points in this slide. The first is that the proportion of people reporting any injection equipment sharing is quite high, and it's quite high both in our NHBS survey as well as our syringe exchange clients, who you would assume, and they do have a lower prevalence than the NHBS participants, but it's still quite high. Almost 2/3 of non-MSM are reporting this. When we look at just syringe sharing, which is certainly the higher risk behavior for HIV transmission, it's still quite common. In NHBS, we see that about 1/4 of MSM report this, and not quite half of non-MSM report this. And as we would expect in the syringe exchange program, these rates are a little bit lower, but still certainly not rare. And the third thing I wanted to point out is that I think the glimmer of good news here is that MSM do tend to be reporting lower rates of injection equipment sharing. So finally, the last result I wanted to share with you is that unfortunately we do see evidence of injection equipment sharing between MSM and non-MSM who inject methamphetamines. These data come from just the NHBS survey, and so among people who reported injecting meth and people who reported sharing any injection equipment, the survey asked about characteristics of their last sharing partner, and specifically asked about the sex as well as whether or not the person was likely ever an MSM. And so among the meth injectors who reported sharing injection equipment, who were MSM, 45% reported that their last sharing partner was a non-MSM. And among men who have sex with women and women, a small group, but still a non-trivial group, reported that their last sharing partner was likely ever to be an MSM. So showing some evidence of network connectivity. Just to recap the data I just presented, first of all, it's clear that at least in King County, injecting methamphetamines is increasingly common among people who inject drugs, and most of this increase is concentrated among non-MSM and people who are injecting goofballs or heroin and methamphetamine together. We saw a signal of goofball use being associated with overdose, and I can say that data from our medical examiner's office also appears to support this, although we don't have an extremely large sample size to confirm that. And we also see that unfortunately sharing injection equipment is common. And unfortunately, again, non-trivial rates of equipment sharing between MSM and non-MSM who inject meth. So I think the key strength of this analysis is that we saw very consistent findings across 2 independent cross-sectional surveys where the variables did overlap. And as I mentioned, we were fortunate to have this goofball measure collected so far in advance of recognizing this as a real trend. The limitations is that we don't have a lot of data beyond what I shared on the injection equipment sharing partners or specific practices. These are all self-reported measures, so they're of course subject to social desirability bias, and there were some variances in the measures between and within surveys. So you're probably asking, why is methamphetamine injection increasing? And unfortunately, these survey data cannot answer that question, but in presenting this and talking with colleagues, I think we're starting to unpack some explanations. First of all, it does appear to be primarily a West Coast phenomenon. Most of the published data on methamphetamine increases as well as goofball use seem to be coming from West Coast sites, including Denver, which we're counting as the West Coast. And at least here in King County, it certainly reflects drug trafficking patterns. So most of the heroin that reaches the West Coast and the Pacific Northwest comes from Mexico. And Mexico is also becoming a hotspot for methamphetamine production. And so we're hypothesizing that the drugs are moving together and that dealers perhaps are introducing both drugs to their clients somehow. This also coincides with the decline in speedballs, which you might be more familiar with, which is the combination of heroin and cocaine. So using heroin in combination with a stimulant is certainly not novel or new. And the data I'm not presenting here is that we did see a decline in speedball use that's perpendicular to the increase in goofball use. But I think the key here is that non-MSM men and women who inject meth may be emerging as a population at risk for HIV, and this is due to that potential sharing of equipment with meth-using MSM, who, as I mentioned, have a very high prevalence of HIV. Fortunately, here in King County, we have not seen evidence of this in our surveillance data. So the new HIV diagnosis rate among non-MSM people who inject drugs is very low. In fact, in our last surveillance report, we only identified 7 new cases of HIV in this group. So we have certainly not seen evidence of this in our surveillance data, which is good. However, I do think these findings highlight how critical it is to maintain prevention efforts among people who inject drugs. Here in King County, we have one of the longest running, Tacoma has the longest running, I see some folks on here from Tacoma, but I think we have the second longest running syringe exchange program in the country. And so we really think that's been monumental in keeping our HIV prevalence so low locally. It certainly speaks to continued HIV testing as well as maintaining viral suppression among people who inject drugs. What I'm not presenting here is that there's a wealth of information showing that MSM who use meth, who are HIV infected, tend to have more difficulty maintaining viral suppression, and so it's certainly important to keep that on the forefront. And then PrEP, and so possibly maybe what these data could suggest is that non-MSM who do report injecting methamphetamines and share an injection equipment may be a potential target population for PrEP. So that's the end of my talk. I welcome any questions.